Now, good afternoon, everyone. We'll just wait a moment while people enter the room. I'm Amy Casey, and I'm the Communication Manager for Endo-ERN, and you're very welcome this afternoon to this webinar. These webinars are an opportunity for you to engage with experts and colleagues within the network, and the topics that are covered are very timely and usually chosen by the main thematic group leads. Today, we're delighted to have a webinar organized by MTG6. I hope that you can see the agenda on the screen, and we have the three members of MTG6, two of whom are chairing the event today. The presentations will go on, and you're welcome to ask your questions when using the chat box on your panel, or at the end, you can raise your hand and I will unmute you, and you can ask your question directly. So at any time, you can put them into the question box and we will take them all at the end. And without further ado, I will hand you over to one of our chairwomen, Ninka Bermes. Thank you, Ninka.
So welcome this afternoon in this MTG6 webinar on septo-optic dysplasia. Well, this is one very interesting ultra-rare condition of our MTG, and well, I think we will have a very exciting discussion today. We have Diana Vitali, the patient representative of our MTG, who has really well, pushed this topic on the agenda, because it is a topic that that is really well, Endo-ERN core business, I would say, and there's so many aspects within pediatrics, between pediatrics and endocrinology, and in interaction with the patients. So I'm really looking forward to the results today. Diana will be the last speaker of today's session, and we have Mohamed Magni from Genova and Mehul Dattani from London as expert speakers, and well, I will co-chair this session with Evangelia Chamandari, the pediatric co-chair of MTG6. After the two talks, we will have a lot of room for interaction with the audience, and Mehul and Mohamed and Diana will also discuss the future perspective and the organization of care. And one of the interesting things was that we were looking for an adult expert on SOD in this organization of the webinar, and we were encountering a lot of difficulties because there are not that many adult experts, I would say, and I think it's very interesting so for adult experts to learn more about this disease. Well, let's start with the first presentation, and I would like to announce Mohamed Magni to talk about the clinical diagnosis with a focus on the endocrine and MRI aspects.
Okay, did you see my slides?
Yes.
Yeah, thank you very much. Can you hear me? Okay, thank you very much, Ninki, and thank you very much, Evangelia and Diana, for the interest in promoting this webinar. And what I would like to, this is my disclosures. And what I would like to share with you over the next 20 minutes is a case presentation with a patient journey mainly, and then go to some issue on the prenatal diagnosis and early diagnosis and counseling. and developed some aspects, some specific aspects of neuroimaging and neurodevelopment burden and some source abnormalities that are related, and then go to some issues of the transition, and then to the summary. So this is a male born appropriate for gestational age for weight and length. The mother's age is 32 years, and I'll come back to this point later in my talk. No consanguinity, no congenital pathologies. Chorionic villus sampling revealed 46XY. This was elective cesarean section for bridge presentation. That's commonly happened in the presence of MPHD, generalized hypotonia. Right anophthalmia was revealed with coloboma, with left microphthalmia and optic nerve hypoplasia. There was bilateral cryptorchidism was associated with micropenis and right kidney hypoplasia, and this sometimes additional congenital abnormalities may suggest the complexity of septo-optic dysplasia. So at 8 months, the length was 70 centimeters, which between -1, -2 standard deviation score, with a target height of 1.5, meaning that the distance from target height was more than 2 standard deviation score. So weight and head circumference less than 10th percentile, frontal busing, micropenis was treated with testosterone for 3 months at 25 milligram intramuscularly. And of course, there was absence of mini puberty, and this could be an early diagnosis of hypo. So here you can see the right anophthalmia and the left microphthalmia. And in the right-hand side, you can see that a few months later, he have deceleration of growth, and he started growth hormone treatment between the age of 14 and 18 months. So the diagnosis of GHD was made. So this is a brain MRI, and you can see here the right anophthalmia and the short arrows, and you can see there is coloboma, and then some additional abnormalities, including the ventriculomegaly and the absence of interthalamic adhesion. So if we look at the sagittal section and T1 and T2, you may see additional abnormalities that includes the hypoplastic corpus callosum, the absence of pituitary stalk at T1, the presence of ectopic posterior pituitary at the level of the eminence, the median eminence. And here you can see some additional abnormalities, including the pons hypoplasia, and I will come back to this. Indeed, with the T2 sagittal sequence, there was a thin pituitary stalk that could be revealed in this one rather than in T1. So genetic evaluation, so they show the gene deletion. So in general, the clinical, endocrine, and MRI findings were suggestive of septo-optic dysplasia and midline defects. And genetic counseling and investigations revealed chromosomal deletion involving OTX2, which is a transcription factor implicated in eyes, craniofacial, and pituitary development. But Professor Dattani will highlight the genetic aspect of septo-optic dysplasia, so I'll not give you any additional information. At chronological age of 8 years, he developed neurodevelopment disturbances. Autism disorder was revealed, and sleep disturbances as well, which is quite common in this condition, leading to the treatment with melatonin. At 10 years, he was diagnosed with hypodipsia with defective vasopressin. I'll come back to this, with defective vasopressin osmoregulation, which could be common in this condition. At the age of 13, central hypo was diagnosed, and he started thyroxine. Anosmia with hypo was diagnosed as well. He started testosterone. And 16 years, he developed epilepsy. Seizures appeared, and he started specific treatments. At 17 years, he developed central adrenal insufficiency and started hydrocortisone, so suggesting that evolving pituitary defects is mandatory in this condition, and that unrecognized and treated or untreated hormonal defect can also contribute to neurodevelopment burden in a child already compromised by visual impairment. At the last visit in 19 years and 8 months, the diagnosis summary was an hypopit epilepsy, autism, and no transition. And we have heard from Ninki at the start in the introduction that it's hard to make any transition, but we'll come back to this later in my talk and the discussion. So let me give you now some insights on the prenatal diagnosis and counseling of septo-optic dysplasia. We know that the majority of cases of septo-optic dysplasia are sporadic and de novo mutation with very low risk of recurrence, and we'll hear more about genetics. In the absence of any family history, recurrence is less than 1%. So in consanguineous families, the likelihood of recessive inheritance is significantly higher, and the recurrence risk is 1 in 4. So indeed, the variable penetrance and phenotypes associated with dominant mutation make genetic counseling very difficult. Is there any prediction for phenotypes? And we'll see more in this. And the presence of family history, and this happened in our patients and families of septo-optic dysplasia. So this in the case of young parents and who needs some counseling. So let me give you just a flavor about the age. This is the Eurocat epidemiological study. Data were from 29 full member registries from the years between 2005 and 2014, covering more than 6 million births, 99 cases with diagnosis of septo-optic dysplasia, suggesting that, confirming that is a rare disease. The prevalence in Europe is approximately 1.9 to 2.5 per 100,000 births. And the prevalence, as you can see on the right-hand side in the figure, was highest in babies of mother aged between 20 to 24 of age, significantly higher in UK. And this is same for age between 15 and 19 compared to the other countries in Europe. And this could be interesting to understand why this has happened in UK more than other countries. So 40% of diagnoses occurred in fetuses with prenatal diagnosis, which make the diagnosis very challenging, but extremely interesting if it's made early, and the anomaly may not be visible at birth in 57% of the postnatal diagnosis occurring over months after birth, suggesting the need to increase awareness about the diagnosis in the first months. So let me share with you some of the tools that may be helpful in the diagnosis for early diagnosis and the prenatal diagnosis. And we know that brain anomalies, at least some of them, are part of septo-optic dysplasia and may be diagnosed prenatally by ultrasound. So some of these imaging were given by courtesy from our ultrasound operators and neuroradiologists. And on the left-hand side, you can see that the septum pellucidum is an essential part of the CNS evaluation, and this in the second trimester by US. And I'll give you additional data on this by MRI. So, and its normal appearance cannot be confirmed by 20 weeks gestational age, and that further evaluation could be warranted by other techniques. So this is a clear example of the eye issues in prenatal diagnosis, and in A, you can see this is a 3-dimensional US image showing the optic chiasm in the axial plane at the 22 weeks fetuses with unilateral microphthalmia. Here you can see in figure B, in the left side, the optic nerve, where you can see the arrow is visible, but the right side optic nerve is invisible. And here you can see in C, the bilateral normal shape of the chia tracts, and this is pathology on D, where you can see the absence of the eye. This is in white, the absence of very thin optic chiasm, the presence of the eye on black, and the presence of the optic nerve as well. So this could be really, it's very suggestive images. There are some limitations, of course, the small field of view, limited ultrasound contrast, the attenuation of ultrasound by fat, and of course the position of the fetus as well. So poor imaging in case of oligodramnus. So in case of such limitations and suspicion of brain abnormalities, MRI could be more accurate. And so no special mother preparation, 4-hour fasting is advisable, and this could be performed since 20 weeks, and it lasts for 15 minutes or more. And here you can see detailed brain development at different time points of 20, 27, and 32. And I would not go, of course, into the detail. So this example where you can see in this 100% after 26 weeks, the pituitary gland could be identified. Indeed, the septum pellucidum could start to be visualized at 10 to 12 weeks of gestational age, and it's fully developed by 17 weeks, around the same time of corpus callosum as well. So and here you can see the example of normal MRI after 26 weeks. And here you can see the absence of septum pellucidum and SOD in septo-optic dysplasia. And here you see the example of absence of corpus callosum as compared to the normal MRI at this age. So now let me give you some information about the neuroimaging spectrum and some information about the neurodevelopment burden and source abnormalities. And of course, this is a septo-optic dysplasia condition, and the visual pathway can be variably involved with optic nerve hypoplasia and with some additional abnormalities of optic chiasm as well and tracts. And this should be carefully checked entirely. So in this MRI, you can see this is a 3 Tesla, and you can see that patient with septo-optic dysplasia as compared to the normal controls have really significant decrease in anisotropy and abnormal diffusivity of optic tracts. And we need to recognize that additional information that include abnormality of optic tracts and optic bulbs could be recognized for smell disturbance and anosmia in these children as well. So this cartoon represents the spectrum of congenital hypopet, which could be not very complex, and you can see that could be additionally complex, some ectopic posterior pituitary and septo-optic dysplasia and additional abnormalities. So the spectrum, it could be associated with major abnormalities and may be diagnosed at birth, while other could be appear later in infancy or childhood with a diagnosis of vision impairment or disability and growth failure leading to final diagnosis of septo-optic dysplasia. In particular, I would like to focus with you to some abnormalities that, in my view, are neglected and that include hindbrain, sometimes forebrain, and more than forebrain is hindbrain. And this many times are additional abnormalities that may be associated with neurodevelopment and autism. So some learning points. Brain MRI, we need to check for anterior pituitary size, presence and position of posterior pituitary, the pituitary stalk absence or not, is the septum pellucidum present, are the optic nerves and chiasm normal, is the appearance of corpus callosum normal, is the appearance of the olfactory bulbs and tracts normal, and are there any other associated CNS abnormalities that may include the vermis and the pons. And I'll come back to this now in this is a cohort that we have evaluated. So 38 patients were enrolled among 50, and these patients have clinical variables that include pituitary hormone deficiency, GHD or TSH, ACTH or gonadotropin defect, with some visual impairment, and all those with severe visual impairment were excluded. And we have analyzed the study by MRI and for developmental. And here you can see in this slide, group A, Group B, and Group C. And Group C is the normal control. Whether this Group A and Group B represented septo-optic patient with septo-optic dysplasia with hindbrain abnormalities or without hindbrain abnormalities. So these are the parameters that we have measured in all these patients. So the anterior posterior diameter of the mesencephalon, the APP of the pons, and the diameter of the medulla oblongata. And then we went for the craniocaudal diameter for mesencephalon, pons, and medulla, and we did some ratio, and then we measured the height of the vermis and the angle of the tegmentum and the vermium templum. All these were analyzed and measured for all these patients at control. And here you can see there was an extreme variability in the biometry of brainstem and cerebellar vermis in the sagittal section. And here you can see that septo-optic patients with brainstem abnormalities show an anterior-posterior diameter that is lower than those without abnormalities and controls. And the same is for the anterior-posterior diameter of the medulla oblongata, and I will not go through all these details, are very technical. The same for the vermis height and septo-optic dysplasia with this abnormality of the brainstem show vermis height lower than controls. And here the same for the ratio, and these patients have abnormal anterior-posterior ratio that was greater than those without any abnormalities. So one of the interesting things we have identified with the 3 Tesla MRI is the tractography. And here you can see in these patients there are aberrant course of major fibers pathway, and this could be due to dysplastic white matter, and these could be very common findings in cortical dysplasia, and these could be patient at risk of epilepsy and seizures. So that might be identified as a risk factor for the development of this condition. So in summary of this study, 6 of 21 patients with hindbrain anomalies had thickened quadrigeminal plate and some aqueductal stenosis and hydrocephalus. 3 had a genesis of the epithalamus. Midbrain, hindbrain abnormalities are significant, albeit under-recognized component of SOD. And patients with hindbrain abnormalities have, of course, all these anatomical, neuroanatomical abnormalities, but this is associated with developmental delay and with epilepsy. So, of course, some significant association between pituitary and brainstem abnormalities were found as well. So let's move to the last part of this talk. It's about the SIRS abnormalities. And here you can see that we did this study because we understood that the severity of developmental delay and neuroanatomical abnormalities could be related to some extent to additional abnormalities, including SIRS abnormalities. So these subjects were stratified based on the anatomical finding that include congenital septo-optic dysplasia with ectopic posterior pituitary, or some with major abnormalities. And these subjects underwent IV osmotic challenge with hypertonic 5% saline at the rate of 0.05 milliliter per kilogram per minute as by protocol, a SIRS score based on 0 to 10 centimeter long visual analog scale according to the methods described by Thompson were used as well. And here's some results. You can see based on this group, the group with septo-optic dysplasia and major developmental abnormalities, neuroanatomies, showed really a defective osmoregulated vasopressin as compared to the other groups. And here you can see clearly that plasma osmolarity was very high, and the platelet secretion of vasopressin was really has a defect in osmoregulation, leading to some abnormality of thirst. And this could be additional risk factor in these patients for dehydration, and even in the presence of obesity, of some vascular outcomes that could be extremely difficult. So in summary, in transition, what happened? This is the last part. We know that puberty and fertility represent a task, and we'll come back to this later. Reevaluation of GHD could be challenging. Careful about the adrenal crisis, learning disability, hypothalamic obesity is another challenge, but now we have new drugs, and we must be careful about this. Desmopressin treatment with SIRS abnormalities and risk should be taken into consideration, the quality of life desires of patient, and the MDT. So just a couple of slides about the GHD and challenging diagnosis, because not all these patients might have more than 3 pituitary hormone defect. And we know based on the recommendation, if you have less than 3 defect, then the growth hormone should be retested. And it's not easy because ITT represent the gold standard, but we know that these patients are at risk of epilepsy as well. They have adrenal insufficiency. They might have adrenal insufficiency. GHRH plus arginine is not reliable, and glucagon and macimorelin have never been tested in transition These are the cutoff reported by the American Association of Clinical Endocrinologists in adults. So some of the barriers for successful transition are related to the optimal timing, what is for these ultra-rare conditions, the time management and MDT, what are the recommendations, what are the experience in adult services, and of course there is some sensitive issue regarding the fertility and sexual development, and clustering of comorbidities compromising the quality of life and independence. So my last slide is suggesting to improve the patient journey. So early diagnosis, mainly prenatal, up to 50% could be diagnosed there in counseling. So, and fast track for genetics could be discussed later on after the whole presentation. And recognize treated hormonal defects can contribute to neurodevelopment burden on a child already compromised by visual impairment. Midbrain, hindbrain abnormalities are significant, albeit under-recognized component of septo-optic dysplasia spectrum, and are significantly associated with development delay in epilepsy. And detailed MRI study could be helpful in recognizing very early these children. And reminding the tractography that could be very helpful. Timely family engagement for formal transition is needed, and provided MDT care that should be uninterrupted, coordinated, and comprehensive. And recognize and increase awareness of septo-optic dysplasia and unmet needs in adult life. And this could increase the access to educational support care of septo-optic dysplasia. And I think this were one of the learning objectives of this seminar this afternoon, and collaboration with the adult endocrinologists. So I would like to thank you all for the attention, for making this seminar possible, and a lot of my collaborators, neuroradiologists, geneticists, and of course patient and family, and Diana. We are collaborating with since many years as an association of septo-optic dysplasia in Italy.
Thank you very much, Professor Magni. We will have the opportunity to ask questions and discuss the topics that will be presented at the end. We shall move now to our next speaker, who is Professor Dattani, Professor of Pediatric Endocrinology at UCL Great Ormond Street Hospital and Institute of Child Health in London, UK. Professor Dattani is going to present the neuroendocrine disorders associated with SOD, and in particular, he will give us information on the single center experience on SOD. Thank you very much, Professor Dattani, and dear colleagues, thank you all very much once again for joining us in this interesting webinar.
Thank you very much, Leah. Can you hear me?
Yes.
Okay, fine. So thank you to the ERN team and to Mohammed and Diana for inviting me. As you're aware, I'm not really an ERN member at this stage, as the UK left the EU, but I hope still very much to collaborate with my wonderful colleagues there. And Mohammed's talk has introduced the topic of septo-optic dysplasia very nicely, so I'm not going to go into that. And we're going to go straight into the lessons we as a team have learned at Great Ormond Street Hospital from our patients over the last few years. And a lot of this work has been performed by my colleague Manuela Cerboni, who was initially from Naples and now works with me at Great Ormond Street Hospital, and to Nicola Improda and to Maria Guames as well, who are both SP fellows. So this is our study. So we have a total of 171 patients with septo-optic dysplasia, of whom 132 are SOD positive, so that's the SOD plus. So these are the children with endocrine abnormalities, and 39 don't have endocrine abnormalities, so they're SOD minus. And then we've compared that population with the children with MPHD here, and also 35 patients with optic nerve hypoplasia. Now you can see that there is a difference in the patient numbers, and that is because our main interest has been in septo-optic dysplasia over the years, and so the referrals are a little bit biased towards that. So we've looked at a number of parameters, and I'm going to present those today. So first of all, if you look at the characteristics, the demographics of the three cohorts here, what you can see is that the male to female ratio, there's a male preponderance with both SOD and MPHD, and interestingly also with the ONH group, but it's not that significant. So it's 55 to 60% males. The age at diagnosis, and you can see here that there's quite a striking difference in that the MPHD patients present much earlier than the other two groups. And overall, neonatal SOD, MPHD, or optic nerve hypoplasia diagnosis in the neonatal period is shown there. And again, the MPHD group are diagnosed earlier. The next column, next row shows you the follow-up duration and the age at the last appointment. And we'll come to the weight gain, but that is also a significant finding in these children. But note that it's not just the SOD group, but also the MPHD group who can put on weight very easily. But interestingly, there's a small cohort of the SOD cohort who are extremely lean as well. And that might give us insights into the hypothalamic function in these children. So you've seen the MRI.
Can I interrupt you one moment? Is it possible that you switch to presenter mode?
Ah, sorry. I'm so sorry I didn't do that. There we go. Is that all right? And then
Thank you.
do I need to change that? Yeah. Is that better?
Yes.
Okay, so sorry about that. So the neuroimaging, Mohammed's already talked a lot about that. And this is our original genetic family from Sheffield. And you can see the classical appearance of SOD here. So this is the normal MRI. And this is the two children. Both had a genetic form of SOD. And here you can see a very tiny anterior pituitary and an ectopic posterior pituitary, very thin corpus callosum, and I think an optic chiasm. And this child, the sister, had a similar phenotype, but less severe, with the posterior pituitary halfway down the stalk, slightly bulkier optic chiasm, and perhaps a little more anterior pituitary tissue. And also the corpus callosum is a little bulkier. So you can see this variability even within the same family. Okay, so the neuroimaging features, when we talk about these, are the anterior, posterior pituitaries, the pituitary stalk, and then overall the pituitary stalk interruption syndrome, where all three of these can be abnormal. And so we looked at our two groups, and the first here is anterior pituitary abnormalities, and you can see that there were fairly similar proportions in both of these groups, with either mainly hypoplasia, but also rarely absence of the anterior pituitary, and in one patient, enlargement of the anterior pituitary. Posterior pituitary, commoner in the MPHD group, and that achieves statistical significance. And this could be either hypoplastic, mainly in the SOD group, or absent as well in the SOD group, less so in the MPHD group. But the MPHD group are more likely to be associated with an ectopic posterior pituitary. And stalk abnormalities are similar in both groups. And the overall condition of pituitary stalk interruption syndrome is commoner in the MPHD group, so more severe phenotype there. So going now to the endocrinopathies, again, you can see that growth hormone deficiency is common in both groups and is the commonest endocrinopathy, no major difference. But TSH and ACTH deficiencies are commoner in the MPHD group, quite significantly. And gonadotrophin deficiency appears to be commoner in the MPHD group as well, and I'll come to that a little bit later. On the other hand, vasopressin insufficiency is more likely in the SOD plus group. And then we looked at the endocrine morbidity score. So this is the number of hormone deficiencies. And you can see here that this was more severe in the MPHD group. And I'll show it to you in a pictorial form in a minute. So here, this is just showing you in a graphical form what I've just said. GHD similar in both, but vasopressin insufficiency commoner in the SOD group, and ACTH and TSH deficiency in the MPHD group. And here you can see the EMS is more severe in the MPHD group. What about the age at onset of endocrinopathies? So the SOD group is characteristically sort of more diffuse in terms of age at first pituitary deficit, whereas the MPHD group the first deficit occurs earlier and seems to be more clustered over a smaller time period. And here you can see again in the MPHD group, all the hormone deficiencies can occur generally earlier, except the GHD, which seems to be similar in both groups. So Manuela prepared these survival curves of the time to the first deficit, and you can see that with the SOD, it's a more protracted development, as I've shown you previously. But with the MPHD, the first deficiency occurs much earlier, and there's more dramatic sort of time course, really. So 90% of the MPHD patients had the first deficiency by 4.8 years, compared to 8.5 years for the SOD group. And this is showing you for each individual hormone, so growth hormone, TSH, ACTH, and gonadotrophin deficiency. And for each of those, the pituitary hormone deficiencies were more frequent and occurred significantly earlier in the MPHD group, in blue there, except for the vasopressin deficiency, which is commoner in the SOD group. And these are the hazard ratios of time to first pituitary deficit, and one can see quite clearly that the most significant is the presence of posterior pituitary deficits, which are associated with earlier development of the first pituitary hormone deficit. So looking at the individual hormones, we've talked about the frequency of growth hormone deficiency. This is the GH diagnosis. You can see that there's quite a wide scatter here with the SOD plus group, and the MPHD group seem to be a little bit lower in terms of their GH. And this is the response to GH treatment, baseline, first year, second year. And you can see that those responses are very good. These children often need very small doses of growth hormone to start with, and we often start at around 10 micrograms per kilogram per day. And they respond well initially, and then we titrate the dose thereafter. This is TSH deficiency. Again, you can see here the TSH values, and what you can see is that the SOD group, they seem to be clustered. But note that in the MPHD group, the TSH may actually be higher. And so even though they have TSH deficiency, the basal TSH may be a little bit higher, but with a low free T4. These are the free T4s at diagnosis, so not much difference between the two. And here there's a treatment doses, the starting dose and the last dose. So this is the SOD group and the MPHD group. Now, you can see that in the MPHD group, the doses that were started were higher, but a lot of these children come from other centers where the treatment's been started already to us, and then we can bring down the dose with time, basically. So you can see the last dose is similar in both groups, and really they don't need much thyroxine to keep the thyroid hormone concentration satisfactory. And we try and keep it in the upper half of the normal range. And this is ACTH deficiency, which can be really challenging in these children, and there's no one test that performs really well. Again, it's common in the MPHD group, as I've discussed previously, and these are the cortisol peaks mainly on synacthin. And you can see that they can be all over the place. We also use an early morning cortisol to help us, and sometimes a 24-hour cortisol profile. So this is really the most challenging to diagnose. And here is the dose of hydrocortisone. So you can see the starting and the last dose for SOD and for MPHD group, and generally they're similar, and we try and keep them between 6 to 8 milligrams per square meter per day, and we titrate the dose based on cortisol profiling, which we do quite regularly at Great Ormond Street and UCLH. The vasopressin insufficiency, commoner in the SOD group, as we've already said. And the age at diagnosis, this quite surprised me because there can be a range, and some children develop it at the age of 5 or 7 years, having never had it before. So something to look out for, really. Okay, the most interesting findings were really around the pubertal findings. And so we looked at puberty at 2 stages, the mini puberty and then actual puberty in the teenage years or in the adolescent years. And here you can see that in the SOD group and the MPHD group, there was a higher number of patients who presented with undervirilized genitalia in the MPHD group. And then we performed GnRH tests in both groups. These are small numbers, really, 16 and 8. But they gave interesting data, really. So this is the peak LH response, which is higher in the SOD group, as is the peak FSH response. And this is the number of patients who had an LH peak less than 5 units per liter. And again, 50% of the SOD groups had that, and 50% had a higher LH. Whereas in the MPHD group, all the patients had a lower LH peak to GnRH testing. And this is the undetectable LH to GnRH test. And again, you can see that the MPHD groups are more likely to have an undetectable LH response. We then did an HCG test to look at testosterone production to 3 days of HCG and to 3 weeks of HCG. And the testosterone was greater in the SOD group as compared with the MPHD group to both the 3-day and the 3-week HCG test, basically. And then we looked at insufficient 3-day testosterone responses to HCG stimulation, and the MPHD group were more likely to fail the HCG test both at 3 days and at 3 weeks. So these give us interesting insights into gonadal function or the HPG axis very early on in life. And then how does that translate to puberty? So this is at adolescence. And so this is the number of patients who achieved spontaneous puberty at the expected ages. And you can see that more of the SOD children achieve spontaneous puberty as compared with the MPHD children or the ONH children. And then likely gonadotrophin deficiency based on clinical and biochemical findings. And again, the MPHD patients are more likely to show that. And then treatment for delayed, slowly progressing puberty, greater in the MPHD group compared to the SOD group. But on the other hand, a number of the SOD group and the ONH group needed treatment for early puberty. And that is something that we see with SOD, that they can go into puberty early and may need treatment to stop that. So this is just showing you pictorially the mini puberty data, which I've just shown you. So the MPHD group were more likely to have pathological testosterone concentrations of 3 days and 3 weeks of HCG, and to have undetectable or low LH concentrations, whereas the SOD group were more likely to have higher testosterone concentrations at both 3 days and 3 weeks of HCG, and higher LH and FSH in response to GnRH tests. So in SOD, the gonadotrophin axis seems to be preserved in a significant number of patients. And this is just showing the puberty treatment for, so the SOD group were more likely to get spontaneous puberty, with the CPHD group were more likely to need treatment for puberty with GnRH deficiency. And on the other hand, the SOD group were more likely to need treatment to stop their early puberty as compared to the CPHD group. So Manuela also looked at the deficits and how they evolve. So as Mohammed very nicely showed in his patient, there is evolution of the phenotype. And she found 16 types of associations of pituitary deficits. The most frequent was GH, TSH, and ACTH in both SOD and MPHD. But the caveat there is not all patients had reached pubertal ages, so the gonadotrophin deficiency is a little bit more difficult. But there is more gonadotrophin deficiency in MPHD, and there's no doubt about that. Diabetes insipidus is more frequent in SOD, and overall there were 70 patterns of evolution. So one really needs to be very vigilant in both sets of patients. Body weight, well, this can be very difficult in these children, particularly with excess weight, although a few patients, as I've said, are lean, particularly in the SOD group. But you can see that obesity is very common in the MPHD and the SOD group, and less so in the ONH group. And severe obesity occurred mainly in the SOD group with a BMI greater than 4 standard deviation scores. Neurodevelopmental delay. So these children are really challenged and their families have a lot to contend with. They can be very aggressive, self-harming, and really difficult to manage. They can also harm others, so one's always got to be careful of that. And again, commoner in the SOD group than the MPHD group. Autism was classified in 24.5% of patients, and these were the ones who had been tested rigorously. But I would think that that figure is probably greater. Sleep disturbances occur in about 35%, and melatonin treatment has been used in some of our patients, and around 40% do improve on melatonin. Mortality, so we had 4% mortality in the SOD patients, 3% in the ONH, and none in the MPHD group. And basically, mortality and morbidity were really linked to the not only to the SOD, but also to other features that were present. The problem is that these patients often die during the night, and so you're never quite clear what happened. Was it cortisol deficiency? Was it interaction between DI and cortisol deficiency? And additionally, all the deceased patients in our group had complex phenotypes with other systems involved. So in MPHD, there's a higher occurrence and earlier onset of anterior pituitary deficits, higher prevalence of severe HP abnormalities. SOD have a higher prevalence of posterior pituitary deficit, wider age range at presentation, and body weight and pubertal disorders. They have heterogeneous hypothalamic pituitary structural abnormalities and also other brain abnormalities. And then the ONH, who have normal pituitary function, but are at risk of hyperpituitarism in some cases because of a small anterior pituitary. And my record is a 16-year-old girl whom I was about to discharge, then presented with a very low cortisol and had no other hormone deficiency. So one's always got to be careful and look out for these. And possible precocious puberty and body weight disorders occurs in both the SOD minus and the ONH group, as well as the SOD plus group. So the limitations of our study is that this was a retrospective study. These conditions evolve, and so this was a snapshot in time, and there were more SOD patients than the MPHD and ONH group, but this is the largest single center cohort that's been published, and there's long-term longitudinal data with detailed characterization. But there are a number of questions that remain unsolved, i.e. why the phenotypes are heterogeneous, and what does a hypothalamus contribute in terms of the phenotype? And that is a big question that we need to answer, and we'll come back to that a bit later. So this is just showing you the morbidity associated with this condition. These eye defects, which can range from mild to severe, as you saw with Mohammed's patient with anophthalmia, the endocrine deficits, and then the other things that they have, temperature instability, which we haven't talked about, hearing loss, olfaction, and obesity, which we have talked about. So I'll just finish off now in the last few minutes with a few insights into the genetic development of the pituitary gland and how SOD really may occur. So normal pituitary development is dependent on a complex cascade of transcription factors and signaling molecules. Many of these signaling molecules are only expressed in the diencephalon, never expressed in the pituitary, yet dictate normal anterior pituitary development. And within the pituitary, there is a cascade of transcription factors which start from the progenitor cells to the defined cell types that we know well. And these may be homeobox genes, such as the HMG family and the TBX family. These regulate gene expression and may be activators, where they activate gene transcription or repressors. The signaling molecules are widely expressed, and increasingly they're involved in cancer as well as development, and that may be a very fascinating link between the disorders we see and the future risks of cancers. So far there have been two main approaches: the candidate gene approach, which included mouse models, naturally occurring or transgenic mouse models, chromosomal abnormalities, or genome mapping strategies, and now next generation sequencing, which is taking over very rapidly, and we'll talk a little bit about that. So we've looked at a range of congenital hypopituitarism disorders, but this is just to illustrate the genes so far that we know about in SOD. So maybe not as many as holoprosencephaly, but the list is gradually expanding. And we're finding more and more, but all of these mutations are quite rare, which makes life a little bit more challenging. So first gene I'll talk about is HESX1, which is the first one we identified. This is a transcriptional repressor. It's a homeodomain gene expressed very early in mouse embryos in a region that's going to form the forebrain and pituitary, but later localized to Rathke's pouch and the primordium of the anterior pituitary and switched off in the forebrain. And then its expression completely stops after embryonic day 13.5 in the mouse. And we were interested because the knockout mice had a very highly variable phenotype similar to septo-optic dysplasia with eye, pituitary, midline forebrain, and olfactory bulb issues. And human mutations were then found to be associated with both recessive and dominant forms of SOD, but also multiple pituitary hormone deficiency and rarely idiopathic growth hormone deficiency. They're rare and they're variably penetrant. So by that I mean the parent may carry the genetic change, which we've shown to be functional, but does not get the condition, yet the child has the same genetic change but gets the condition. So it's something that remains to be explained. I've shown you this already, so we'll skip that. And then the second gene I'm talking about is the SOX2 gene, and this is very important for pituitary progenitor cells and the development of the pituitary from its earliest stage. But it's also important for the development of GnRH neurons. So we've performed conditional knockouts, i.e. just in the hypothalamus and pituitary, and we found reduced proliferation of the progenitor cells in the pituitary, reduced GnRH neurons, and interestingly, reduced PIT1 cell types, and that is the somatotrophs and thyrotropes in our mutants. In humans, the phenotype is hypergonadotrophic hypergonadism as far as the pituitary is concerned, with rare GHD, a small anterior pituitary, or paradoxically, a pituitary mass, as I'll just show you. They also have severe eye defects, esophageal atresia, hearing difficulties, and learning difficulties. And this is a patient from Argentina who presented quite early on and had this big mass, and then developed hypergonadotrophic hypergonadism, and the mass remained the same for around 18 years until suddenly it grew rapidly, and she then had panhypopituitarism instead of just gonadotrophin deficiency, which is what she started with. And that remains unexplained to date, and other patients have also shown similar findings. Mohammed's talked about OTX2, which is expressed early in murine development and is important for mouse forebrain and hypothalamic development, and we think also for HESX1 expression. Mutations are associated with eye defects, which can be mild to retinal dystrophy, to anophthalmia and microphthalmia. They also have cerebellar abnormalities, variable hypopituitarism, as Mohammed has shown, and which can evolve, and they generally have small anterior pituitaries and an ectopic posterior pituitary. So here you see two posterior pituitary signals, one in the right place and one ectopic, together with a slightly small anterior pituitary in this child who had an OTX2 mutation. And we've now reported a number of cases, including Mohammed's case as well. And you can see that the phenotypes can be quite variable, but GHD is a constant. They can get microcephaly and neurodevelopmental delay, and variable eye phenotypes as well. So this is the Wnt signaling pathway that I'm talking about next, which is important for pituitary development and tumorigenesis. And mutations of beta-catenin have been shown to be associated with craniopharyngiomas. But in this context, it's a very important molecule. It's held in a complex for ubiquitination and degradation, and it keeps target genes of Wnt signaling pathway repressed in the absence of the ligand. When the Wnt ligand comes along, it breaks up that complex. Beta-catenin moves to the nucleus, and this whole process becomes activated, and target genes become activated. So we were interested in a gene called TCF7L1, which is important for stem cell pluripotency, cell lineage determination, and brain development. And my colleague Carlos Gaston Massuet at the Royal London Hospital and at Queen Mary's University made a conditional knockout of this gene in the hypothalamus and using the Hessex1 Cree. And what he found is a phenotype similar to septo-optic dysplasia with partially penetrant forebrain and eye abnormalities, and in addition, neural tube closures. These are the mutants compared with the normal mice here and here. And you can see that these mice often lack the eye over there and have truncated forebrains. So what happens to the pituitary function? So they have reduced amounts of growth hormone and TSH, but not ACTH. Prolactin is slightly reduced and the gonadotrophins are also reduced. The mice were very small, and you can see the growth curves here of the mutant mice compared to the normal control mice. So they were very small. And then we screened our cohort for mutations and found two significant variants, which we tested functionally. I'll show you that in a minute. In two patients, one had pituitary abnormalities with SOD, the other one only had SOD but no pituitary abnormalities. So moving on, this is a child, this is a family really of 6 children born to 3 pairs of first cousin parents, and they had early onset DI, ACTH and TSH deficiencies. They had severe visual impairment, an initial cerebral sparing with progressive microcephaly, seizures, cerebral palsy and global developmental delay, dislocation of the hips, and hydronephrosis with vesicoureteric reflux in these individuals. 3 subsequently died of sepsis. And basically, so it was a highly complex pedigree with many children showing death in the first few days of life and even intrauterine deaths. Their MRI showed a small anterior pituitary and generalized reduced white matter of the brain. And the growth phenotypes were quite interesting. So here, the height was very low, but the weight was increasing quite rapidly. And in this individual, they were growing normally, but as soon as the weight came down, the height also dropped. So very unusual phenotype. And in 2 of them, we did overnight growth hormone profiling, and they had hardly any peaks of growth hormone secretion. So this is a variant in a gene called ARNT2 on chromosome 15, and the affected children were all homozygous. It was a recessive form of inheritance, and the mutation we found was associated with complete lack of function. Now, this is called aryl hydrocarbon nuclear translocated 2. It's a transcription regulator, member of the basic helix loop helix per sim family, important for hypothalamic development. And basically, it binds to SIM1 as a dimer and also to HIF1 alpha. And it's expressed very widely, including in the hypothalamus, but also in the ear and the retina. And the murine knockouts had very similar phenotypes to our patients, with absent or hypoplastic paraventricular, supraoptic, and anterior periventricular nuclei, and absent or hypoplastic posterior pituitaries, deficiencies in oxytocin, vasopressin, CRH, TRH, and somatostatin, and they die within the first week of life. So this is a hypothalamic gene giving rise to an SOD-related phenotype. And we may learn more about the hypothalamus and its role in this condition as time goes on. Again, there's a cascade, which I won't go into in detail, of all of these genes, but I think we need to learn more about that. And then we found mutations in patients with cardiofacial cutaneous syndrome associated with septo-optic dysplasia. So we thought, are these 2 unrelated disorders, or is there a link here? And then we looked at the literature, and our cardiofacial cutaneous syndrome is due to BRAF mutations. It's a rasopathy, like Noonan syndrome, but more severe. And we found that many of the children have been described to have GH deficiency, precocious puberty, and hyperlactins, optic nerve hypoplasia as well. And this is a common BRAF mutation, which can also give rise to adult onset papillary craniopharyngioma. And so again, we looked at our patients and we found BRAF mutations in these children with CFC and SOD, and the phenotypes were variable with growth hormone, gonadotrophin, ACTH, and GH deficiencies as well. And the MRIs showed absent septum pellucidum and small anterior pituitary glands. And so Carlos did some functional studies of this and found that the mutations were activating compared to wild-type mutations. And then he did the mouse knock-in of this mutation. And again, the mice were very small and they had a small anterior pituitary and they failed in terms of their growth. So again, a hypopituitarism phenotype. And we showed that there was a reduction in GH, TSH, prolactin, and LH, but not ACTH. So ACTH secretion was in fact increased in the mutant mice, which we still haven't explained. And then finally, rounding up, there are a number of other genes that have been described. FOXA2, which gives congenital hyperinsulinism, also hypopituitarism with colobomas and other liver, lung, and GI tract abnormalities. And it's expressed in the hypothalamus, the neural tube, and the pancreas. And then RAX, and this is described by Professor Brachet from Belgium. And this individual had bilateral anophthalmia, cleft lip and palate, and signs of hypopituitarism, including vasopressin insufficiency. MRI showed anophthalmia, no sella turcica, presence of a pituitary stalk, but the anterior and posterior pituitaries could not be seen, and a complete cleft palate. And this is a truncating mutation, and there is a mouse knockout which shows that the infundibulum fails to form and the Raskay's pouch does not invaginate properly. And it's critical for forebrain iron pituitary development. So overall, the incidence of mutations so far is rare in SOD, commoner in those with severe eye defects, with SOX2 and OTX2 account for the majority. But I think we're using whole exome sequencing now and finding new genes, and I think that figure will probably go up to at least about 15%. We're working on the functional significance. So just to remind you, these are very pleiotropic phenotypes. What is hypothalamic? What is pituitary? We don't understand that at present. Mutations are generally rare. The inheritance is variable. The penetrance is variable, suggesting other genes and possibly environmental factors may be implicated. The phenotypes can evolve, as Mohammed showed very nicely, and careful interpretation is required because we still don't understand these conditions fully and the genetic basis fully, particularly with the variable penetrance. Novel causative pathways are emerging, and we'll learn more about those over the next few years, but we do need to take care with genetic counseling. So SOD is a spectrum, really, of malformative conditions involving different brain structures with heterogeneous, complex, and highly unpredictable endocrine phenotypes. And I've talked a lot about obesity, diabetes insipidus, autism, neurodevelopmental delay, and early puberty, all of which are more likely in SOD, whereas those with MPHD develop a more homogeneous phenotype. And the MRI findings can predict the evolution of endocrine deficits to a limited extent, but lifelong surveillance is necessary. So I'd really like to thank Manuela, who is a much cherished colleague of ours and still is very active in the field and looking at hypothalamic structure and development. Maria Guamez and Nicola Improda, who worked very hard as SP fellows, and Angie Wade, who provided statistical support for the studies. And this is a very important slide. I'd like to thank all the collaborators at the Crick Center, particularly Ian Robinson, the funding sources, all my collaborators, all the patients and families, and all the people who do the hard work at GOSH and ICH. Thank you for your attention.
Thank you very
much. Thank you. Oh, excuse me. Evangelia.
No, please go ahead. Thank you very much.
Oh, I was, well, we swapped the roles. I'm sorry. Mo, thank you so much for presenting. And I would move on to the next speaker, Diana Vitali. We're a little bit behind schedule, so Diana, I hope you can present in 10 minutes.
Yes. So I will be very short, because I really think that it was very important to have a presentation by Mehul and Mohammed, and I'm really happy to contribute to the realization of this very important webinar. And I want to say that it is the very first time that the SOD and the SOD spectrum are at the center. And I really want to thank Mohammed and Mehul, who are my superheroes. And I also thank Nyanke, Evangelia, and Johan de Graaf who put up with my insistence on the topic of SOD. And of course, I thank all the staff of Endo-ERN with whom it is an honor to collaborate. So I have a strong, oh my God. Okay, sorry, I ended to move this somewhere else. And I think I will close this. Sorry. So my presentation is called 2024 SOD Odyssey. And an accurate diagnosis is the first step towards caring for those living with SOD or other neuroendocrine disorders. For patients and families, it can save the life and years of worries and inappropriate management. In 1988, for my daughter, it was a real odyssey just to get a diagnosis. This is our past. Today, sorry, today, what has changed in the perception of the disease and the quality of life, and what are the needs and the expectation for the patients? The past lives in the present, and our journey is still has some problem. When you or a loved one is facing a difficult or a life-threatening health condition, a straightforward journey to diagnosis can make all the difference. But for many people with SOD or other neuroendocrine disorders, the arrival of that route, the diagnosis, is by no means the end of the odyssey. And this is our present. Diagnosis is only the beginning of a long process of awareness. The patient has to find his way, together with other patients, together with the physicians, together with research, together with the pharmaceutical industry, together with health policies, with the healthcare centers and social institutions. The person with SOD and his family, as you see, have to deal with health aspects that are extremely difficult to manage and truly life-threatening, and where the signs and the symptoms can be confused and difficulty recognized. So not only life-threatening, but also with high impact in quality of life and complex challenges in everyday life. In a situation extremely challenging, desperate, and often resigned, the person with SOD may not find a clear point of reference. This is the real problem. We still have to build the entire frame, the coordinates in which patients can find his way. But does not always has to be in this way. I like to think that in this time we have a great opportunity. It is necessary to join. It is our time and it is our responsibility. And I think it is necessary to join forces and work together to transform the reality of this disease, take it in an instant toward the future we dream of, and finally realize our vision where no one with SOD is ever left alone to struggle with this condition again. This is our challenge, being increasingly specialized and yet remaining human. Thank you.
Well, thank you so much, Diana. It's a wonderful plea for collaboration and for future development of care for SOD and other rare diseases. I think we move forward to the panel discussion, the future perspectives and organization of care, and the needed research.
So, can you hear me?
Yes.
Yes,
Yeah,
yes.
okay. So I'm going to present on behalf of my colleagues, and thank you, Diana, for that wonderful presentation, which really is thought-provoking, and that's why we're here, really. First of all, I think it's important to talk a little bit about the transition of these patients. When I first started, I remember a lot of my adult colleagues did not know about the condition. And now gradually that's changing. So transitions defined as the time between the completion of puberty, achievement of peak bone mass. It's complex and difficult, should begin in early adolescence, and also complicated by changes in education, lifestyles, greater independence and high-risk behaviors, and learning and neurobehavioral difficulties add further complexity. So what issues are there in patients with SOD and hypopit? Well, adherence to medication changes, growth is coming to an end, pubertal induction and fertility need to be considered. Weight gain is a major problem. Low bone mineral density. So do we continue growth hormone, and how? How do we optimize bone health? Substance abuse and alcohol intake, they will experiment, and that also gives us further problems. And hypothalamic dysregulation, which is a key feature in these conditions. And the timing must be optimal. Now we have longer-acting glucocorticoid preparations, long-acting GH, depo-testosterone, and that might all help the young person cope with the conditions better. Learning difficulties and neurobehavioral disability need to be addressed, and they need input, particularly at this sensitive time. Visual impairment needs to be thought about. There's a need for an MDT with social work, psychological input, as well as clinical nurse specialists and medical professionals, pediatric and adult physician support. And retesting needs to be considered. How do we retest with the minimal discomfort to these families? And this can prevent complications such as short stature, poor reproductive function, morbid obesity, reduced bone mineral density, and a poor quality of life. But MDT is really key to the whole process. So these are I just sort of list the issues here. Growth in SOD. So these are the questions for clinical research for the future. These children have very variable growth. Often, even with growth hormone deficiency, they can grow, but gain a lot of weight. So what's the role of the weight in preserving growth? Why does this phenotype occur? Evolution of the phenotypes, we still don't understand that. What is the timing of the endocrinopathies? Is there any rhyme or reason to it? Why does that evolution occur? What's behind it? Preservation of puberty. Why do they show early puberty in some individuals, normal puberty in others, and delayed puberty in yet others with gonadotrophin deficiency? What about vasopressin insufficiency? So Mohammed spoke about that, and the thirst, which can be quite abnormal in these children. And what's the role of the ectopic or undescended posterior pituitary? How does it impact on posterior pituitary function? A number of children have an absent posterior pituitary, yet do not have diabetes insipidus. So are they going to develop it later? Learning and behavior, high prevalence of autism, which can be extremely difficult for families to cope with. Self-harm, aggression towards others, variability in learning. So I've got some patients who are going to university and one doing a master's with her visual impairments. Some of them are absolutely amazing. Sleep can be a major problem. Olfaction is a problem. And weight gain is one of the biggest problems in this condition, with no real game changer instead of medications as yet. We're hoping that the newer drugs may be it's appropriate, but we have to wait and see. And the variability of the clinical course, like the genetics, there's huge variability in growth, in final height. Some of them seem to do well initially, but then at the final height, puberty just races through and they end up quite small. And puberty we've talked about. The neuroradiology Mohammed's talked about, but always be aware of associated brain malformations. We need to look and see, do these correlate with learning, neurodiversity, and behavior? And then the genetics. So genetic variants are rarely identified. There are an increasing number of genes, but each with few cases. And now we're beginning to identify more than one gene, and we've just run a panel of genes on our patients, and we're finding some very interesting data suggesting oligogenicity. The variable penetrance is interesting, and we haven't as yet found an answer for that. And this may be associated with the or related to the incidence in children of younger mothers. bringing in epigenetics. So future epigenomic analysis, looking at what's hypothalamic, what's pituitary, may help us. And finally, this is a slide from Diana, and she asked me to talk through just a little bit, through it a little bit. So registry is very important for SOD and generally broader hypothalamo-pituitary disorders. MDT approach. So we've started SOD clinics, and these are specific clinics in a quiet area that's comfortable for this challenged cohort. Some of these children have hyperacusis, so they get very disturbed by the minimal sound. So you've got to be very, very careful how you handle that. Holistic care, and also input from endocrinology, ophthalmology, neurodevelopment, psychology, physiotherapy, and OT is vital. Networks within the ERN and wider Europe. These are rare disorders, so people can tap in to the expertise of bigger centers for better care for the patients. Healthcare equity, equitable access to care, and equitable experiences regardless of the region in which the patient lives, and access to genetic counseling, although we're still a long way away from definitive counseling, except in the consanguineous pedigrees. So future care and research must integrate the unmet needs of patients with needs for improvement in the areas of obesity, hypothalamic syndrome, neurodiversity, fatigue, rehabilitation, disabilities, emergency management, and new possibilities for improved lifestyles. So I'll stop there and we can discuss this and take any questions.
Thank you very much. Thank you very much to all speakers for their excellent presentations. Are there any questions or comments?
And no questions from the audience yet. Maybe Mohammed can add some words to Mahul's prior discussion.
Yeah, yeah, it was very nice, very nice one. I would like to ask Mehul, I didn't have any interpretation for why and the Eurocat registry. I mean, there is so a significant difference between the early presentation of septo-optic dysplasia in UK compared to the other countries in Europe. Is something? Do you believe there is some additional factors that might be related to this?
I mean, yeah, I mean, it is an interesting question. I mean, I guess we don't know. I mean, that incidence is quite striking, I have to say. I mean, I guess one of the factors may be that I think the UK population may be a little bit more diverse than some of the other countries. But, you know, it's still quite difficult to explain, I guess. And I mean, you know, there is a cluster in cities, and that was shown quite nicely by sort of Peter Clayton's group in Manchester, and also the Younger Mothers Association that's been shown in both Glasgow and Manchester. So, you know, there are little sort of hints, but I think at the moment we just don't know.
I have another question related to obesity. So in our cohort, I can tell you that we don't have 50% approximately as in your cohort of obesity, and we have rather a lot of patients who are thin. So this is our extreme. I mean, you know, between obesity and normal weight, we have even thin patients. I mean, several thin patients. I don't know why, how to explain this one as well.
That's really interesting because our experience is, as you saw, completely the opposite. And, you know, I just dread the weight gain in some of these young patients because it just almost is a vertical takeoff, you know, after the age of sort of say 4 or 5, some even earlier. Yeah. And it is so difficult to do anything about this because these children are so challenged. Their parents cannot restrict their diets. It's so similar to Prader-Willi, the phenotype in some of these patients. If the parents try and restrict the phenotypes, the child gets very angry and upset. And so, you know, it's challenging for the parents to cope with. So the easiest thing is give them what they want. And this is something that we're seeing a lot of. So, you know, and there is, I think there probably is a sub cohort that is just much more likely to get that weight gain. But really, there's a very small proportion of our patients who have a completely normal weight, and a tiny proportion who are lean, but those are much smaller. The weight gain is a big problem.
So do you think this is hypothalamic in terms of behavior, or the pathway of MC4, leptin and MC4 receptor could be involved in these patients?
Yeah, I mean, I think that that's very likely. But, the question is, why is that different from, say, what you're seeing? Because you would anticipate that the problems would be similar in different cohorts. But certainly, I mean, they have a very hypothalamic phenotype. So the behavior, the weight, the sleep, some of them don't have as big an appetite as you would expect for that weight gain, and the parents are very vigilant, yet they put on weight very easily. Now, confounding that is obviously they're visually impaired, they're not very mobile. So that's also a challenge. So you've got so many different issues there that impact on the young person, and I think trying to tease out one from the other is challenging.
Yeah, if I can add something, Ninki and Evangelia, about this, because something that in clinical practice I have realized that those patients with severe eye impairments. So I wonder whether the conscious state related to, smell, related to eye, could be much more and deeply impaired, leading to absence of obesity. But this is a theory.
I mean, the other end of the spectrum is also that the sleep disturbance, which really can be very striking. So I've had families that say that, since the child was born, they haven't slept properly because the child doesn't sleep and they're sitting there and want stimulation. And we now know that there's a lot of literature on the importance of sleep in weight regulation. Does that also impact on it? And that's another factor, I think, that for future research.
Yeah, sure. There's one question from the audience. Amy, could you unmute? Unmute her? Shirley Nips?
Yes, hi there. Yes, I'm in Cape Town in South Africa. I'm a grandparent of a 20-month-old boy. He was born 20 months ago, as I mentioned, to my 19-year-old daughter. And he was diagnosed at 4 months. There's not much information about this in South Africa. There isn't almost zero support. We take him to the Red Cross Children's Hospital for the various clinics, and we don't really get any feedback at all with regards to his condition or what the next step is and how we can make his journey that much easier or help him reach his milestones. I see that in your presentations you mention a lot about the stats and the children that you've dealt with in Europe and in those areas, but in Africa, or rather in my country, I feel all alone. I don't feel like there's anyone that knows where we are. We feel like we've got no help, but we don't know what to expect. We don't know what to do going forward with him, and he's such a joy. He's very thirsty, and now today I understood to a point over and above all the medical terms why he could be thirsty. It's actually his condition. He's also visually impaired, although he reaches for my cell phone whenever I have it in my hand, but he'll try and make his way across the floor and bump into the window, for example. So he's always got bruises on his forehead, and we're just glad that he's moving around, but we don't know how to encourage him to walk. We don't know whether we should be encouraging him to walk. We've just the basics, so all the research is great, but on the ground with us parents or grandparents, I mean, my daughter has her own issues with the fact that her son has this problem, and she's struggling with it mentally because she thinks it's her fault. But me as the grandparent, I've stepped in and I'm his primary caregiver, but I've got no idea. I don't even know where to start to try and help this child. And a lot of what you've said during your presentations makes a lot of sense to me and rings true with me, and I identify with a lot of the symptoms or you know, things that he's doing that you've mentioned, and it really just helps knowing that there are people out there that are trying to help us in the corners of the world, you know, because we really do feel all alone out here, and we don't know who to reach out to help us. And you know, the pre-puberty thing and the autistic thing, that's very scary. And yeah, and he's only taking cortisol and he's taking thyroid meds, but he doesn't really go very often to the Red Cross, so we don't really know what we're doing, to be honest. I don't know if there's anything that you know of locally or somewhere that we can contact, you know, a group that we can contact for help, or you know, or do we just hang about?
Yeah. Thank you so much for your question. It's of course always very difficult to go into depth into personal questions, but maybe I could ask Mahul or Mohammed to give some general advices that are also important to other listeners.
So, Mohammed, shall I start and then
Yeah, go ahead.
So, I mean, can I ask, has he had a scan, and does that that clearly shows a pituitary abnormality?
Yes.
Okay,
Yes,
so,
yes, he has.
Yeah. So, and you said he's very thirsty, is that right?
Yeah, he's very thirsty and he urinates quite a lot.
So, yeah, I mean, that needs to be looked at. I mean, has he got diabetes insipidus? And that can be done by blood tests.
Right.
And I think that would be my first thing to make his life a little bit better. And how old did you say he is?
20 months.
Yeah, and so his growth will probably likely be abnormal as well. So he will probably need growth hormone treatment as well. And the sooner you start, the better it is at a low dose. Okay, so those would be the first couple of medical things. But he really needs input from neurodevelopmental pediatricians if you can find someone. Now, there are endocrinologists and presumably neurodevelopmental pediatricians in the biggest cities and the bigger hospitals, because they come to our European Society of Pediatric Endocrinology meeting. And if you were really challenged, we could always try and point you in that direction if you let us know. But that would really be my first sort of thoughts. Unfortunately, there's no easy answers. He will need to be closely monitored and given all the input and stimulation that he will need over the years.
Yes, exactly. That's the problem, as we, you know, I kind of reach out to try and listen into these kind of webinars so that I can try and learn something myself and, you know, try and preempt or prompt this kind of, you know, questions at the doctors that we do go to, but they're not very well versed in this condition. So, exactly. So, you know, we kind of, I just try and grab straws wherever I can and try and learn a little bit more on what we can do. But thank you for that. I appreciate your feedback. Thank you.
Yeah, thank you. And I think Diana recognized, well, of course, in a different country, different setting, the unmet needs of good centers, isn't it, Diana?
Yes, of course. Also in Europe, when you have a diagnosis of this condition, it's very difficult for the family. And I always say the most important thing is that the endocrinological aspects are taken care at the best and in a specialized center, in a very high specialized center, because that's the most important thing. The other thing can go on, and little by little the family understands something more, and everyone does the best for the development. Yes. But for the parents with this kind of diagnosis, is always very, very difficult to understand. It's a long way to the awareness, and as I said, it's important that this is something growing up all together with the physician and with the hospital. So it's also important that you insist in your area to create something more well done.
Okay, great. Thank you so much. I really appreciate it.
Just one point. I mean, I hope he's on hydrocortisone at reasonable doses 3 times a day, because I've had people from abroad recently who've been on once or twice a day, which really is.
He's on 2 mils at 6 in the morning and 1 mil at 2 in the afternoon and another 1 ml before he goes to bed.
3 times a day. Good. Okay.
Yes.
That's
it.
very important. Yeah.
Oh, good. Thank you. Yes, no, we'll do that. We definitely do that. Thank you so much, doctors. I appreciate it.
Thank you. Thank you. May I also ask a question to Mehul and Mohammad, please? Thank you all again for your excellent presentations. Now, in childhood and adolescence, there is in most tertiary referral centers, there are very well developed multidisciplinary teams to manage these patients successfully. And thank you again for sharing your data with us. Do you happen to know what happens once those patients are transferred to adult care? Do adult physicians have equally well developed multidisciplinary teams for the management of those patients? And do we know what is the nature of the condition throughout adulthood? Are there large studies for adult patients with SOD?
Shall I start again? Yeah. So
As you wish.
the answer is the answer is no to that last bit. There are no large studies of adult patients because it's rare. Okay, and I just my worry is that sometimes they're lost, like we saw with the CAH study, right?
Yeah.
And I think in the UK we haven't got it right, Leah. Okay, so I've started a transition clinic with Helen Simpson, and for her it was a steep learning curve because she'd never seen these patients before, and now she's gaining that expertise because they move over to her, and so she gets to know them and the problems. So I hope that that's the start for us, and I hope that other centers could sort of have similar trajectories. But it is a big problem. I remember when I first started in the field, my ophthalmologist David Taylor said to me, Mehul, all you hear about is that these patients with visual impairment go on sort of trips abroad or whatever, and then suddenly die, and no one knows why. So it just makes you think.
Yeah, but now that we have been using the registries in the Endo-ERN or generally for rare diseases, I think it would be an opportunity to monitor the progress of those patients if we join forces throughout
we
Europe.
absolutely have to do that. We absolutely have to do that.
Yeah. We will learn a lot.
If I can add something, I mean,
So
we don't have.
Mohammed.
Please.
We don't have any transition program or process for these patients because, as in Prader-Willi syndrome, the issue of autism behavioral is very difficult. It's not a matter of endocrinology because adult endocrinologists are fine with the endocrine parts, but are not at all confident with the neurobehavioral part and all these disturbances as well.
Yeah.
So there was another question of the audience, whether you can comment on the following. If there is a sibling or anticipated pregnancy wish in a family with a SOD case, do you have any suggestions what kind of analysis could be done in pre-conceptive stage, so anticipation on a new pregnancy?
So Mohammed, you were talking a little bit about that. Do you want to start off with that?
I mean, I can start that. In this case, I mean, of course, ultrasound and MRI are both indicated because transabdominal ultrasound is very helpful. And as said, there are markers for this, and together with MRI, because these families ask for counseling. And if you don't have any fast track genetic evaluation, which is not easy, and we don't have, and we know that there are only few genes. So to this, I can leave this comment to Mehul because this is something we have discussed with our prenatal geneticist and with our prenatal operators. And it's very difficult to have a fast track for genetics in fetal cells or something like that to make a diagnosis easy.
Yeah, I mean, I would agree, and I would say that recurrence risk is extremely low, except in consanguineous pedigrees. And so that's a different ball game. In consanguineous pedigrees, you do need to look hard at the genetics and see if you can find something. But in other pedigrees, it's really low, and it's really difficult because you find potentially pathogenic variants in other family members who are not affected, and yet the child in front of you is affected. So there must be something else. There's a second head that's doing it. And so, you know, the next pregnancy may carry a variant, but actually the child may be fine. So we're nowhere near genetic counseling at that level for most sort of heterozygous changes at the moment. So I think one has to be extremely careful.
Yeah, but anyway, ultrasound and MRI could be extremely helpful because they might rule out the codominant conditions or even autosomal recessive conditions in the absence of CNS abnormalities.
Yeah, and I think that's the way to go at the moment. Yeah.
Okay, thank you so much. Any other questions? Yeah, I was wondering myself whether there are any concrete questions for those adults. Of course, you need a multidisciplinary team with the neurobehavioral aspects as well, but just for medical surveillance, what would adult care need to comprise? What would we need to do? Do we need to do scans? Do we only need to follow potential new endocrine deficits and metabolic screening? Can you comment on that? What would you suggest?
So, I mean, I think by the time I transition, I normally sort of have decided that they will need adult growth hormone. So if they've got, you know, 2 or 3 hormone deficiencies and an MRI abnormality, I would just change the dose to an adult dose without retesting. And then I think I'm increasingly using prednisolone with the permission of my adult endocrinologist because it's so much easier in these children to give it twice a day rather than battling with 3 or 4 doses. So again, that's a major change. And then, you know, if they haven't got certain hormone deficiency, but they have a structural abnormality of the pituitary gland, then yes, early morning blood samples, 6 to 12 monthly would be important. And the parents are counseled as to what to look out for in the interim. So those are the main things. I don't bother repeating the scan if they've had an abnormal scan initially. The one cohort that is a little bit unknown at the moment is those that have a small anterior pituitary and may not have developed any hormone deficiencies. And what do you do with these patients? So I'm hoping we'll get more data to guide us over the next few years, but that's a bit of a challenge.
Yeah, if I can add something, is the issue of adherence is extremely important. So long-acting glucagon could be fine. Yeah. The issue of hydrocortisone with life-threatening in this condition is high, and be aware about those patients with chronic dehydration and source abnormalities that are at high risk in case of surgery or something else, at high risk for coagulopathies and strokes. So this, in the presence of obesity, this could be an additional risk. So, and epilepsy. So these are things that we had to bear in mind in the transition as well.
And I was triggered by the ARNT deficiency, the genetic one. And is there any connection with the AIP syndrome?
Yeah.
Do you know?
So, yeah, it's intriguing, isn't it? But so far, we've not found any potential link, really. Although it can form heterodimers, but we've not found anything yet.
Yeah. Well, yeah, I think we need to have further discussion in future about composition of multidisciplinary teams. Of course, there's a core team, and you need extended team depending on the situation. Do you want to add something on this? how do we proceed?
Ooh, that is $1 million question. It's resource, I think. That's a problem. In the UK, it is so, I mean, psychological support is like gold. You cannot get it, especially once they're over 17, 18. It's really painful to see the families suffer, but we just cannot because they're huge waiting lists. And, you know, you send them to CAMS, which is the Child and Adolescent Mental Health. They'll say, no, they're too old. And then trying to find adult services is really challenging in the current climate. So I think, you know, it is such an important part for these patients so that they can have, you know, as much of a normal life as you can try and give them. But, you know, they're big obstacles.
Yeah.
So
I think
until
that
governments realize that. Yeah, sorry, God, Mohammed.
no, I agree with you about resources, but I think that we increase awareness and general practitioner involvement is better than nothing. So it could be nice to involve also this by increasing awareness about these conditions and what are the risk factors for these families, because besides South Africa, I don't know where they were based, but this could happen even in Europe, I mean. So resources is not it's not easy to get. So I think that involvement of other, I mean, GPs or somebody else could be helpful through the ERN network.
Yeah.
Leah, can you comment on how the situation in your country?
I think we have very limited multidisciplinary centers for adult patients with SOD in our country as well. And I was thinking, as we were discussing this issue now, that perhaps the responsibility lies on our adult endocrinology colleagues who are at the center of this multidisciplinary service. Perhaps our adult colleagues have to take the responsibility to initiate the development of a multidisciplinary meeting for those patients in adult care and liaise with all necessary colleagues to address their health problems.
Yeah, well, we will think about it.
Yes.
One last question. Is there underdiagnosis in this condition? Do we miss a lot of cases?
I would say almost certainly. And there are cases that come to you much later than you know, you would like. I remember one patient with a child was a year old and was drinking a lot, and the local doctor just said, oh, well, you know, just give him what he wants at night. The mother put 10 bottles of water around him at night, and he would reach out and drink each of those, and the penny just didn't drop, even though he had visual impairment. So I think, yes, there is underdiagnosis out there.
And even in the adult
with sleep disturbance there, Mehu.
Yes,
because
exactly.
it was awake the whole night.
I know. It's very difficult. It's really difficult.
Yeah. And even in the adult age, could there be like cases of congenital, well,
if you don't have severe visual impairment, because some of these patients have monolateral optic nerve hypoplasia associated with GHD or less severe endocrinopathies that could be missed and underdiagnosed.
Yeah.
I mean, the ophthalmologist now will refer any child with optic nerve hypoplasia. So we've got to that point, but I don't know whether that's the same in all countries or certain European countries only. But that needs to happen, really.
Yeah. Any outstanding points? Leah, do you have any questions left?
No more comments or questions. Thank you very much.
Yeah, so I think we had a very enthusiastic, great webinar today. Thank you so much to all speakers and initiators. Thank you so much, Diana, for pursuing this webinar. Mahu and Mohammed, thank you so much for your presentations. Leo, and thank you for co-chairing today. And Amy, thank you for the organization. It was great. And well, there will be a next Endo-ERN webinar from another MTG in the next coming weeks. And I want to close this session and thank you so much for listening.
Thank you.
Thank you so much. Thank you.
Thanks. Thank you very much.
Thank you. Bye-bye. Take care.
Bye.
Bye-bye.
And thank you all
Bye.
colleagues who joined us. Thank you.